Hi there, folks. My name is Khan. As you all know, we're going to be talking about reproductive disorders and hypogonadism today. This is an overview for our topic. It's going to be what actually is hypogonadism. We're going to talk about then diseases and treatments in terms of men, and diseases and treatments for women. That's a pretty easy cutoff, as there are actually very disparate outcomes in there. So first, we're going to talk about what androgens are. Now, this is usually the cause. This is the culprit of a lot of problems in the world, but especially in this topic. Made primarily in the testes and ovaries, is the most potent androgen, and it's very easily converted to both DHT or estrogen, depending on which you prefer. Now, DHEA is another androgen. It's not as potent. It's made in the adrenal gland. Okay, it can be converted to testosterone, however, in the periphery, and that sometimes leads to issues as well. Now, in men, what's testosterone used for? So it's needed for appropriate sexual development, okay? You're a man, this is why. It also needed, however, for skeletal formation and maintenance, so it can lead to issues later down the road, especially in aging. Bone marrow function, also dependent on testosterone, both men and women. But more importantly for us, it's muscular development and maintenance, so you can see issues with that. But also, sense of well-being, as we all know, libido and potency as well. So you got low T, you're not feeling good about it. Now, what happens here? How is this controlled? So it is it's a hormone controlled by the pituitary gland and the hypothalamus. So first, you're going to have gonadotropin releasing hormone, which released by the hypothalamus. It's going to go to the anterior pituitary, and it's going to send out LH and FSH to the testes. FSH, sorry, goes to the Sertoli cells, and the LH goes to the Leydig cells. L with L. That's how I try to remember it. It's going to send some negative feedback back up to both the anterior pituitary and the hypothalamus. I know none of us remember this chart. But then Sertoli cells are going to get positively reinforced by the Leydig cells down over there. And that's what happens. Now, what is hypogonadism? Okay, so it's going to be defined as a reduction in the testosterone production overall. Okay, that's what it is. You can happen due to primarily testicular failure. Secondary causes are going to be hypothalamic or pituitary dysfunction. Combined causes are there, rather rare, where you're going to have decreased pulsatility of the gonadotropins from the hypothalamus, but then also a decreased Leydig cell response. So it's going to be a combination of both things. Treating that's a little bit on the tricky side. You can also have them be congenital or acquired causes. Can also, a lot of times it's multifactorial. That's when it'll be the combined cause. Aging, disease, your own habits, and certain medications that you're taking. Now, so of all of the men with hypogonadism, only 5% are actually currently treated. This extra slice shouldn't exist, but as it were, that's what the case is. Okay, so it's actually a very undertreated disease, especially amongst our fellow colleagues. Causes, back again, we're going to have
which colleagues?
Primary testicular failure,
6 of us.
Hypogonadism, hypogonadism, which is Colvin syndrome or pituitary adenoma. Trauma is a common cause, as well as idiopathic. On the other side of things, more on the habits side, you're going to have obesity, systemic illnesses like HIV, cause wasting syndrome, certain medications that you're taking, changes in various hormones, GnRH, prolactin, cortisol, and thyroid hormones can cause these kind of issues, as well as a normal part of the aging process. Now, primary hypogonadism. That is the inability of the testes to make testosterone, either in response to hormones or they just can't, the factories are shut down. You're going to have, again, because they're not doing their negative inhibition, you're going to have high levels of LH and FSH. This is actually the most common form of hypogonadism in men. It'll happen a lot of times from toxins like chemotherapy or radiation. Okay, so people with various cancers, that's what you're going to look for. The most common genetic cause is Klinefelter syndrome, which, as a reminder, is a 47 chromosome addition, 2 X's and a Y. It's pretty common, 1 in 500 births, actually. You're going to see small testes, gynecomastia, and azoospermia, which is a fancy word for the swimmers don't want to swim. Another cause, kind of rare now, mumps orchitis, okay, due to the MMR vaccine, but you'll still see it in outbreak regions. So certain populations that are not being vaccinated for various reasons This is going to be a cause right there. Currently, that place is Disneyland and Minnesota, where that would possibly be endemic. Ketoconazole, popular drug that we bandy about, can also cause this, especially for people that have like athlete's foot, ingrown toenails, and you just want to throw them on 10 months of ketoconazole. You got to think about that for a minute. Another common one for people who are a lot more active is injury or torsion, and that's not something any of us would like. Now, this is back to Klinefelter syndrome, trying to give you a look at the body habitus, because that's actually going to be one of the first clues for you that, hey, they're coming in for some kind of reproductive disorder and they look like this. We should look down that pathway. So you're going to see they're going to be very tall people. Okay, they're going to have their nipples are going to be wide spaced as well. They're going to kind of have some minor breast development. Okay, the testes are going to be small. Okay, less than 4 milliliters, which we don't remember what that means. That means they're in Turner stage 1, or Tanner stage 1 rather, and they're also going to have a female pubic hair pattern, not like yourselves. Secondary hypogonadism. It is due to abnormality of the hypothalamus or the pituitary gland. Okay, lower normal LH and FSH, but you're also going to have a low testosterone along with it. Commonly secondary to a severe illness or exogenous anabolic steroid use for this cause. Common syndrome will also have this. This is a hypothalamic inability to make GnRH or make it in the pulsatile fashion that it needs to be. This is going to be associated with anosmia. Now, I don't actually know any other illnesses with that besides like some strange seizure syndrome. So if somebody says they can't smell right, they got this.
Parkinson's?
Parkinson's will have it too. Okay. They don't look like they got Parkinson's, they got this. Infiltrative disorders like sarcoidosis, Langerhans cells, hemochromatosis, and again, that's going to mess with the ability of your pituitary hypothalamus to actually send out that GnRH in the fashion that it wants to. Prolactinoma, again, going to damage that area. That's where they all are. Other pituitary tumors. Trauma, and once again, irradiation. So if somebody either gets chemotherapy or radiation therapy for another head tumor, or they work in a radiation zone, so that would be a cause. Now, the effects very much depend on the age of onset, because we use them differently at different times in our lives. So if a neonatal period, they are denied testosterone that they require, you're going to find problems like cryptorchidism, microphallus, ambiguous genitalia. If it happens in the pre-adolescent stage, before puberty, you're going to have lack of secondary sexual characteristics, unicoidal body habitus, similar to the common syndrome picture, except for the tall stature. Gynecomastia and prepubertal testes, again, that's the less than 4 milliliters. In adults, what you're going to find is infertility, decreased libido, potency, decreased energy and muscle mass. You're going to have mood disturbances, decreased bone density, and then maybe their testicular size that was normal, 15 to 20, will start going down as well. And also you're going to have a different consistency of the sperm is what you'll also find. Now, who's screened? So according to Endocrine Society, International Endocrine Society, not everybody, okay? You need to have certain risk factors, and you can use a fancy questionnaire. So we'll actually go into that in a minute, but some of the conditions that are related, that have a high prevalence of low T in them, it's going to be, you have a cellular mass, again, pituitary and other such kind of adenomas, radiation to that area, or some other kind of disease, okay? Treatment with medications that can affect it, glucocorticoids, ketoconazole, opioids as well. Another reason to stay away from the heroin. HIV-related weight loss and other wasting syndromes. End-stage renal disease and hemodialysis will also have this. And if somebody wants to help me out and call these guys back. Moderate to severe COPD will also lead to hypogonadism. Rough stuff. Don't smoke. Osteoporosis or a low trauma fracture in a young man can, again, lead to testosterone because of disturbances in the hormone release. And then type 2 diabetes. Catch all for basically everything. That's the new cigarette smoking. Now, back to the low T quiz. If we'd all participate. These are yes or no questions. There's 10 questions. Do you have a decrease in libido? So if you know, just answer that to yourselves. Do you have a lack of energy? And do you have a decrease in strength or endurance? Have you lost height? Have you noticed a decreased enjoyment of life? Are you sad or grumpy? Are your erections less strong? Have you noticed a recent deterioration of your ability to play sports? And are you falling asleep after dinner? Right after dinner, not, you know, the normal time. And has there been a recent deterioration in your work performance? Do you now? So here's the thing, this is the best part. This was validated on 316 Canadian physicians, so this is indeed upon our colleagues. Very high sensitivity, by the way, you guys, so sorry. But it's not that specific, overlaps a lot with general depression. But that being said, if they were then, we'll get back to what's a positive on this actually. So the only things that you need to be positive are actually 1 or 7, and then one of the last 3. So just 2 of those.
So what's the point of asking 2 for 6?
Distractors to see if they are more on the depression side of things. That's the thing. Lost height doesn't have anything to do with it, evidently. So, you know, if somebody answers yes to all of them, they're just like, hey, just, you know.
So the big ones are 1, 7,
And so you need one of these 2 plus one of these.
Okay.
Okay, that's how that works. Since you got 9 out of 10, I'm you know, we're gonna check you. But the interesting part about this is very, very significant increase in life quality after treatment. 12 out of 13 that were positive on the Adams test and showed chemically low T. They were treated after 3 to 4 months, dramatic improvement.
So you do, you're probably going to go into this, but you do like the questionnaire with the worrisome symptoms.
That's right. So this is like the screening questionnaire.
What testing do you do after this?
And yes, we will absolutely go into that. But again, so some of the more specific signs and symptoms, you're going to have loss of libido and erectile dysfunction. You're going to have mood changes. You're going to have fatigue. You'll have osteoporosis, so we don't got that one yet, I hope. Loss of muscle mass and strength, some regression of secondary sexual characteristics, and oligo or azoospermia. So, how are you going to come across a patient like this? First and foremost, of course, good H&P. You got to ask the the hard-hitting questions here. You're going to ask about puberty and when it started for them, how they developed, secondary sex characteristics initially, how their libido is, any potency, history of congenital defects in them as well as in their family, anosmia, orchitis, and drug use. You're also going to want to take a look at them, take a look at their body habitus. You're going to try to test for gynecomastia, see about loss of virilization in this case, and testicular volume. Now, the assay is actually a rather simple one. So there's 2 that you can get, either the total testosterone or the free testosterone. We'll talk about those in a minute. You want to get the AM sample. It's like cortisol. It's highest in the morning. That's the peak that you're looking for. Okay. Now, a total serum testosterone is going to be the free plus bound to protein. Okay. Now, it's usually very tightly bound to sex hormone binding globulin. That's its job in life, as well as albumin. The normal is between 300 and 1,000. Okay, this is an available test here for us. But then the free testosterone, non-protein bound, that's about 2% of the total amount. That's actually a send out. For some reason, it doesn't make sense to me, but nevertheless, that's between 35 and 155. Okay, that would be the normal ranges for that. So what you're going to do over here, you guys know I love my maps. So somebody's going to come in, they're going to be complaining about things. You're going to decide that you want to give them the Adam questionnaire. Okay, you're going to get that morning total T. It's normal. You're looking down the depression pathway. Okay, you're going to say follow up, try some of these other things. Let's change your lifestyle a little bit, see what we can do with that. Okay, but now it comes back low. All right, you're going to look for reversible illnesses, drugs, or nutritional deficiencies. Okay, that's the other thing. Remember, this is a protein-bound thing. Lifestyle can change it. If they got a wasting disease, they've changed their life for some reason, whatever happened, you got to look at those things first. Okay, reversible causes. You're going to look at the LH and the FSH. Then you've confirmed that yes, it's indeed low from the total. You're going to go ahead and you're going to check, okay, what is their LH and FSH compared to this? Okay, so let's say it's low T and low or normal LH and FSH, that's secondary cause. okay? You're looking at something up here. Now, but if they have high LH and FSH, brain's trying to make it, you know, say, hey, come on, let's get at it. That's a primary gonad type. Then you're going to go down looking at karyotyping, okay? Look for that Klinefelter syndrome. That's a little simpler. The secondary cause, you start barking up a forest instead of a tree. You gotta look at prolactin, you gotta look at iron, other pituitary hormones. You want to look at MRI under certain circumstances if you believe that they do have mass effect symptoms. That's what we're going to go there. Now, treatment depends on lifestyle choice. Does the patient desire continued fertility or do they not? Okay, so that's going to affect it a lot. If they don't, then you can treat with exogenous testosterone. It's a simple thing, but there are many side effects associated with that. Don't use oral testosterone is the thing. I don't think it's available with us to us anymore in the country, but back when it was, very high variability, bioavailability amongst patients. So it's essentially, dosing of it is impossibly difficult. And also a very high risk for liver toxicity. Okay, long story short, the choice is testosterone or their liver at that point with the orals. So what's used now are testosterone enthanate, which is a IM formulation. They get it once every 2 weeks, and we'll talk about that. It has much less physiologic problems. So that's what it looks like, you know, good old doping. That's what folks do. And not that expensive, actually, I found out. But anyway, what happens is this. You're going to get it, and about a day or so, it's going to reach its max value, and it's going to start slowly coming back down to what it was at your normal base. 10 to 14 days, that's what it takes for it to totally get out of your system. So that's why that 2-week dosing came in. Then we have a more fancy way of doing it, transdermal patches. You know, a lot of people like patches around here, fentanyl, nicotine. We can add this onto it. It's a 5 milligram patch. This dosing needs to be titrated then, okay? Depending on the patient, you can add 1 or 2 patches onto them. They used to have a transscrotal application. However, that was not too popular with the patient clientele that we had for whatever reason. So we didn't, you know, we just do it other places now. That is very good, attains stable and adequate levels, but patients do have problems with skin reactions. You can see why the transscrotal approach didn't work too good. But also patches were falling off during vigorous activity. So you start with like 1 patch a day. You check T levels after 3 to 4 weeks. The goal is to be in about the mid-normal range, which is a little bit higher than 400. This is what that looks like. You know, not too bad. But then this is what some skin reactions would look like. So, but
I'm going for it though.
oh yeah, yeah,
He's not giving up.
He's like, you know, let's tell you. According to some things I was reading, you feel real good after this. It's just like the glucocorticoids. But some other things I wasn't able to find more pictures of is you actually get skin blistering reactions. So that would not be fun in any sensitive areas.
Pretty sure you put on like 3 at the same time. Look at it.
Actually 5.
No. The other 2 like
1, 2, 3, 4, 5 for this
those 3
guy.
look like it's the same time.
You mentioned the 2 different types of testosterone testing, like the serum bound versus. Is there one that's preferred, or is it either?
The total is actually the one I think
total
that
is
you
the
need to
preferred.
get. Let's look
Why
at
was
this
it
algorithm
choose?
again. So it says you do the total
promoting
or
total.
free bioavailable. However, all of the things I was reading later, they were always referring to the total serum bound.
Okay, I've seen more.
That's the thing. There is reason to do the free one in certain cases of follow-up, but not for diagnosis.
Okay, and then as far as treatment goes, is there a method that's preferred or that insurances want to pay for? Or?
So the injection seems to be the cheapest thing.
Okay.
However, again, it's inconvenient. You have to make an appointment. Patients do not get that at home
Yeah.
because of doping reasons.
Yeah.
Transdermal patch, however, is pretty popular. I don't think any insurance troubles it. We will talk about some other ways as well. So this is the profile of the androderm patch. Okay, again. This is in hours, okay? So this is a once a day thing. It's gonna go up and then it's gonna slowly level off right about to normal. Now this is not after day 1, this is after day 30 of having been taking this. So this is kind of like what their steady state would look like. It's gonna follow very much the normal diurnal pattern. So patients actually like this the most.
So are they trending it with the free or the total?
So this trend is gonna be with the free, the total. This is the total number, not the free one. So as I said, later, all of these values are going to be essentially the totals. the initial algorithm showed the free. There was like one other cancer following case when they followed the free one.
But it seems like they followed the total.
Yeah, and it appears that's a cheaper lab because that's the one that's in-house. The free one is sent out. That's the case over there. Very popular, testosterone gel, okay? Stuff's almost over the counter. Anyway, you just take it and you just rub it over your body, okay? In certain places. Rarely causes skin irritation, unlike the patch. You can get similar steady state levels, however it is twice a day application. Patients very much like it. However, there's a problem skin to skin transfer, okay? Rub up against somebody, they're gonna start getting it too, even if they don't need it. So this is not at all advertisement, but this is a popular kind of one that is available on the market. This is where you apply it, you know, where men, of course, like to get, you know, massages and such, on the shoulders and belly. And this is the profile of this one. So this one dips just a touch after about 12 hours where they want to give it again. This was not, you know, twice a day pattern. This was once a day. So as you can see, after about 12 hours, it goes down and stays steady. So they decided this one should be dosed twice a day, but people still love it. Works real good. Now, this is a fun one. Transbuccal. Okay, take a little tablet, stick it above your gums like a chewing tobacco, and there you go. This is also, again, also twice a day dosing. Okay, certain subset of the population, I'm sure, asked for this way of getting it, and they got it. So the value of this one is that there's no need for dosing titration.
Oh.
That's what they get. That's it. This is what you get. It's like Xarelto Plavix. You got it.
Huh.
Okay. Again, pretty good levels on this. Once more, dips down after 12 hours. You're going to want a second batch more of them. Now, this is the fun one. Okay, so this is a new one. It's available in the U.S. now. It's a transdermal pellet. Okay, that can be injected in the subcutaneous tissue in the skin. You can put 3 to 6 at a time. It'll last for 3 to 6 months, however many pellets you want it in. So this is just like the birth control pellet.
Yeah. Do they have to go fetch it afterwards, or is it?
I believe they do.
They do. Okay.
Yes.
So I've actually put these in a person. It's kind of violent. The needle's about that big.
Mm-hmm.
Real silent.
Yeah.
Is that FDA approved?
Oh yeah, this is available now. You want this?
You literally have a scalpel, you make an incision, you put the thing in there, like jam it in their muscle, and then put like 2 sutures.
So this one, you don't need to do the scalpel incision. This is entirely the applicator. It's just a nice big steel, large gauge needle, and it has a little push thing where you just go and go plop, plop, plop as you pull it out.
Yeah, but what?
I don't know
But
about
what you?
plop, it's like slam.
That sucker is huge.
Oh yeah, yeah. Hey. What's the biggest gauge needle y'all ever put in somebody?
Like 6'8". Like,
This is a 2 gauge needle right here.
Don't break me.
I'll put it in, but
But the pellets themselves, as you can see, it is less than the size of a dime. So it's not so bad, according to these guys. Now, let's say in the chance that the patient does require fertility, okay? This straight testosterone placement is going to be a problem in that case because it will cause testes to become smaller. It'll halt sperm production or at least impair its ability. If they have functional testes, okay, and it's a secondary problem that they're having, you can give them actually HCG, which is LH, plus or minus FSH, so that they can maintain testosterone levels as well as fertility in this case. The other thing that can be done is a dose, pulsatile dose GnRH. Haven't seen that one. So the much more popular way is the LH plus or minus FSH. This is going to increase the intratesticular testosterone levels, which is what you want, and definitely you're going to have more spermatogenesis, and infertility can become solved. Now the monitoring is to get the total T into the greater than 400 range. Don't use in patients, however, with androgen-dependent malignancies, prostate or breast cancers. Okay, men can have breast cancers as well, so don't brush that one under the pillow over there. You're also going to monitor hematocrit for polycythemia. Okay, as we know, testosterone will increase bone marrow production. You're going to have a little bit more red blood cells. Our good buddy Lance Armstrong loved it for that. But a side effect of polycythemia is that your blood becomes very much prone to thrombosing then. So you're going to want to try and prevent that. Above 17.5, you got to bleed them. Okay. Sorry, no, that's the hemoglobin. Hematocrit above 54, I believe, you need to bleed them. You're also going to monitor the prostate-specific antigen and refer them to urology to get DRE if needed. Okay, we'll talk about a case about that. Another thing that it's going to do is going to exacerbate sleep apnea. Okay, for whatever reason, you got too much testosterone, you start snoring more. You don't need to monitor lipids or LFTs anymore. Liver toxicity is essentially not a concern with these non-oral types of testosterone. But they can still develop gynecomastia, funnily enough, with this therapy. Now, the possible prostate changes. So there are some studies that were trying to measure this. It does show guaranteed growth of the prostate. However, rarely do patients show any kind of lower urinary tract symptoms. So it's not too much of a concern until the patient starts complaining about it. You're gonna check for the PSAs. There's a theoretical increased risk, and we'll talk about that case. There is an increase in prostate volume. It may stimulate the growth of undiagnosed tumors, so if they already have it, it'll make it worse, but it's not going to cause it. The drug companies are very specific in saying does not cause tumors. But you do need to follow the PSA at 3, 6, and 12 months, and then annually afterwards, okay? If it increases more than 1.5 within the years, you gotta refer them to urology, or if it becomes above 4 total, you're gonna refer them. And that's not the usual number. The usual number is 6, but in this case, there's no messing around with it. So what happens with diabetes, which a lot of our patient population has with hypogonadism? You're going to see a higher incidence in them. Okay? Again, whether it is due from the disease directly, whether it's an incidental lifestyle choice, that's what's happening. Especially with diabetes type 2, somewhat with diabetes type 1. Okay? You're also going to see a lot in men with metabolic syndrome, low T. Symptoms of diabetes and hypogonadism kind of overlap, so sometimes we don't ask about it. Okay, you're just going to say, yeah, I've gained some weight, I lost some muscle mass, I'm kind of tired. You know, we think that, oh, that's just a sleep apnea, things of that nature. So you need to see, actually, if they have diabetes type 2 insulin resistance. If you give them testosterone, is that going to improve their insulin resistance? Going to get their glycemic control better? So that's a common thing that I don't think we used to think about. And so here's what happens in some treatments. Okay, they studied 132 patients, 19 to 68. They gave them topical testosterone for 3.5 years. All right. They measured the effects on body composition, mood, strength, their liver functions, sexual function, as well as hematocrit. And we got some fancy numbers there. So the bottom thing is supposed to say years instead of percentage, but their fat mass drops significantly. Okay, you can see massive reductions in fat mass and a quite moderate lean mass increase. So all in all, just better for patients' body appetites. You're going to see their bone mineral density increase. Okay, fractures in old age, very common. People don't like it, so we try to get rid of that thing. The blue is controls. Okay, and after 3 months, the testosterone candidates are significantly better in their bone mineral density. Effects on lipids? None. There's no graph. Didn't do anything. Now on the hematocrit and the prostate, so this is a little funny. You'll see after 12 months, so first 12 months essentially nothing, but then dramatic increase in the prostate volume after 12 months. However, very rarely patients actually have any lower urinary tract obstructive symptoms. So even though it's growing, they're not actually doing anything about it. Now the hematocrit very quickly rises in the first 3 to 9 months, but then it kind of plateaus. And the rise isn't usually that much. It's usually from about an average of 42 to about 46. Okay, then you're like, all right, that's still okay. And that's what's going to be happening there. The PSA does, though, quickly rise and, again, maintain a maximal effect. So that's what you're going to be trying to watch for, that it just stays there. Okay, if it back to this one. If it totally goes above 4, you're going to refer them to urology for biopsy and further testing. If they have symptoms, you're refer them to urology. And if the hematocrit goes above 54, that's a phlebotomy. Okay, and then possible dosing adjustment as well. Now, mood, you're going to have increased positive moods and decreased negative moods, which is, I think, is good all around. So I think testosterone is good for all of us. The effects on erections and sexual activity, you're going to find that most men are going to have a high increase in their satisfaction. They're going to have a substantial decrease in the times of inability to get erections. And you're going to have doubled, essentially, libido and sexual activity. So all in all, good for everybody. Effect on prostates, again, continuing with that topic. So there was one patient in the study that developed urinary tract symptoms requiring a TURP. Okay, he's not a cancer, it was just BPH. One of them, however, had that should be 0.85 to 1.11 increase in the PSA. However, that patient, that one patient, so they weren't concerned for the cancer in that one. 7 of them had greater than 5.5, okay? So they had much more extensive biopsies done. 3 of them ended up having prostate cancer. The suspicion is that they were already existing. And again, just to rehash, the theory amongst the Society of Urology is that eventually 100% of men will get prostate cancer. It's just the nature of our genetics. But that doesn't mean that that's what's going to kill us, because it's very slow growing. Rarely are there metastases, but if there are, they're usually to bone, and that's very painful. So that's usually why they still sometimes will recommend removal. But the incidence, again, of greater than 5.5 was 7%. So it was thought that it's still okay. If they got low T, it's safe to give. Okay, you should highly consider that option. But the idea, again, is that older patients, you got to watch them closely, because they just already have a possible chance of having prostate cancer. This will make it worse. You want to be very careful about watching their symptoms and their PSA levels. So this is just a little bit of fun things about what the lack of testosterone does to us. Okay.
Gives you a giant ugly beard.
I thought this was a fantastic
One of
beard.
the-
Huh? Just a little mental break, shifting gears. And also, I like that man's hat. I would like to have that one day. Now, again, the effects in aging is a little bit more of a story time. Longitudinal studies show that testosterone is going to decrease about 1.6% per year in men after the age of 30. And the bioavailability of it totally actually decreases 2 to 3%. It's gradual, unlike menopause. Okay, so sometimes we don't even notice it. It's like, oh, they've been like that for years. Not to be dismissed. Highly variable. Not all men are going to become hypogonadal. Okay, it can happen due to cause of decrease in testosterone production, increased clearance. You're going to have increase in the binding globulin, because remember, when it's bound, it's not active and doing its job. You can also possibly have a decline in the Leydig cell count, and again, there's many reasons for that: exogenous toxins, injury, other things. So this is what it kind of looks like. So your testosterone total level, this is the bound level, it'll start going down. Surprisingly, somehow, in this thing, they showed that the free T index went up from 80 to 90. But that's generally not the trend. It's all downhill after 30. Sorry, guys. This is some more of it. So we're using 325 as the cutoff of declaring it hypogonadism. So you're going to see, though, that should have been 12.5%. By the time they're 50, 12.5% of men are going to have hypogonadism. By the time they're 60s, 19.5%. In the 70s, 28%. In the 80s, 49%. Okay, so roughly half of the population will clinically match this criteria. The SHBG levels do increase with age. So if you were to shift it over to measuring the free T instead of the bound T, the prevalence is even higher than these numbers. So we have this fun thing called andropause. Okay, and is it real? Hypogonadal men sometimes will have symptoms of aging. Very rapid aging. You're going to have decreased muscle mass. You're going to have increased fat mass. You're going to have decreased libido, bone mineral density, cognitive function, decreased memory, and a sense of well-being. Again, a lot of overlapping with depression and the habits of being depressed. So that's some of the things that we try to figure out. But those, additionally, is it only testosterone's fault? Are there other hormones that might be at play here? Growth hormone, DHEA, those are other things that are disturbed by age. So you're going to have a lot of visceral fat that's correlated with how little T you have. T goes down, visceral fat goes up. We are familiar with this, some of us at least, more than others. But there's no clear cause and effect on that. The correlation between muscle function and low T is very high, but again, not clear if that's the only cause. Okay, you're going to have varying results. There's no clear pointer saying low T leads to reduced sexual function, but it may be associated with erectile dysfunction, and in that case, it works. The Viagra type medicines, they work better when T is added to them, so something to consider. Somebody says it doesn't work. And it may also be beneficial in people with cardiovascular disease. No clear recommendation on that though. So, in summary, is many aging symptoms are going to be suggestive of androgen deficiency, but there's weak correlation between that and actual plasma T levels. So there's no actual goal-directed therapy in that available at this time. Many factors cause it. Other hormones may be confounding this picture. Growth hormone is the likely culprit next that they suspect in this pathway. But men who do not have low T to begin with, there is no documented benefit of supplementation. It's only side effects from there. Okay? So don't try it. Just do other stuff, like sports. So again, causes, it's going to be decreased Leydig cell mass and function for in old age. You're going to have some disorders possibly of LH secretion, and the negative feedback loop isn't going to be working properly. Again, hypothalamus and pituitary have decided they want to go on vacation more than often. And unlike in young men, you're going to mostly, this is going to be secondary causes, okay? So it is going to be indeed hypothalamic and pituitary cause rather than primary dysfunction. So the way to diagnose that, you got to go by the symptoms essentially, because the T variability isn't much there. You're going to check the morning testosterone. Total can be misleading. This is the case where they're going to try to say you have to get the free assay, but evidently they don't like it either because they say the tests are inaccurate. You want to check what's bioavailable, so whether it's bound to albumin or not, but there's no standardized way of being able to assess the tissue availability of just testosterone with these folks. So you're going to go with the total, but recognize that that's not always the end-all be-all, okay? If it's less than 200 though, you got less than total 200, the diagnosis is very clear. And if it's greater than 400, it's for sure they're not deficient. It's in that the normal cuts off at 300, but if their symptoms don't quite match up, you may want to consider other options with these folks. Alrighty, so that's kind of what it looks like. There's calculators available online. You can go ahead and check it. If they have protein calorie malnutrition, you want to be able to check to see what they've got. Okay, and we can go ahead and do that. So the benefits of replacing testosterone in these folks is that, remember, it's going to improve the lean body mass. You're going to have better correlation of sexual dysfunction in the elderly folk. But there's no for sure hard outcomes that have been measured. Decreased mortality, decreased bone fractures, orthopedic surgeries, decreased MIs, anything of that sort. So the whole thing is that, is this going to become the next estrogen with these folks? Okay, well, what did I do here? I skipped a bunch. No problem. Yes, so the idea is that estrogen, they used to give it to everybody in menopause timing, but now they've just seen that there's a lot of side effects with that, so there's some controversy on what everybody should be getting it, okay, and the answer is no. So this may end up being like that. Don't give it to everybody willy-nilly, but there is a subset of the population that may greatly benefit. Okay, so again, another brain break. Patient will be charged extra for annoying the doctor with any diagnosis from the internet. This is a sign I think all of us should be putting in the patient rooms. Here's another fun picture. I did not take this, nor did a friend of mine. This is from the New Horizons telescope that went past Pluto in 2015. this is Pluto itself with the sun in the background. And you can see some small dots in the periphery. That would be the stars. Thought we'd zone out on the black picture for once. Now on to the very important topic of androgen deficiency in women. So in men, similarly, you're going to have to check the DHEA and the testosterone levels. These decline normally in aging, particularly after they've had an oophorectomy, because that's where women make testosterone, or some kind of adrenal failure, which is common mostly in women. By age 40, it's 50% of what it was for women when they were 20. So their rate of decline is rather fast. But it doesn't drop quite as much as what happens with women's estrogen during menopause. That drop is much more dramatic. So they don't often notice it too much. It's hard to biochemically define in women. The reason for that is because the free T assays are not good on the very low ranges of testosterone that women typically have. So a lot of variability there. And the total, again, is also not so much better because, again, amongst the population, they have very differing amounts of SHBG. So it's no way to actually properly standardize it and say that, hey, that's what we should be directing our therapy towards. The testosterone levels directly are not associated with any kind of sexual function or dysfunction otherwise. Again, not a lot of good data on that. Some of the benefits of replacement. First, not a lot. All right, they're not entirely sure that women are going to have testosterone deficiency. So yet. So sometimes you can say, okay, some of them, if they have decreased libido, you may want to, 25 to 3% of them have it, but they don't care. So it's not a problem. Subclinical, if you will. DHEA replacement in women who are hypoadrenal has shown some improvement in those kind of symptoms when there's a direct cause, but that's about it. Don't give them testosterone. The thing is that transdermal has been given surgically to women, okay, and as well as naturally onto women that have estrogen, that have menopause, are being given estrogen already. So they're trying to balance out both hormones in them. So they can get a 300 microgram patch. They wear it for 24 weeks. Supposedly, it increases their sexual encounters, and that was statistically significant. So they said there is a benefit. To whom we are yet unsure, but the other measures of mood, libido, sense of well-being, and just general distress, those had much more mixed outcomes. It wasn't as clear, the data, as it was with men, okay, where there's a definite clear benefit. And again, there's unsure of the side effects of giving long-term testosterone replacement. So in women's case, I would be more hesitant towards prescribing them that. So you can give it for people not taking estrogen. Okay, that's a different study, not the previous one. It was double-blind, randomized, all that good stuff, placebo-controlled, and it was a surgically given as well as naturally given to women not on estrogen. 150 or 300 microgram per patch, 2 different dosings, applied only twice a week. All women met the DSM-4 criteria for hypoactive sexual dysfunction. Outcome measured at 24 weeks, followed by 52 weeks, and that's what they got. So 814 women, 71 finished, 71% put up with the 24 weeks, 57% put up with the 52 weeks. These are the things that they measured: number of satisfying sexual episodes, sexual desire as measured by the 1 scale, and distress by the personal distress score. And this is what they found, that there was significant increases to women not on estrogen, that there was mood and lifestyle benefits.
My mom gets a testosterone pill injected into her butt every month.
Okay. So I think that would be, does she take estrogen?
No.
She does not. So her.
She used to, but the place she goes to now is doing the same thing.
Okay, and I think this is
more aggressive.
Is that so?
Mm-hmm.
Okay.
But when she doesn't get it on time, she cries a lot though. So I'm like, it's working.
Absolutely, and that's the thing. This study with women not on estrogen shows much more benefit again in mood and lifestyle. So perhaps there is something to that. We have an anecdote right here that suggests that that may work. So that's the thing. We should be doing that. And again, this is the satisfaction score. Okay. Oh, sorry. No. This was a satisfaction score. The distress score is next. So again, much increased satisfaction across the board. Maybe y'all need a little bit more. But again, these are not dependent on baseline testosterone levels at all, okay? Because those are just bad to measure, can't get data. No difference between the surgical or the transdermal patch option. So if your ma may prefer that, that may be a thing. But of course, the 300 microgram group had above normal for women range of testosterone. So there is that. Suggest a 150 dose. Again, common problems like with men, they're going to have skin irritation. They may have hirsutism in those areas that they're applying it, actually. Much more in the 300 microgram group, again. Acne, again, in application site and generally. 4 women develop breast cancer. Again, not sure if it was primary already there undiagnosed and this increased the size of it to noticeable.
How many total?
4 out of 814.
Oh.
Okay, so again, it's entirely possible that it was incidental. 10% of the 300 microgram group had vaginal bleeding. Other the 150 and the surgical had 2.6%. Okay, so again, menopausal symptoms once more. No changes in liver toxicity or anything else. Okay, so the long story short, the 300 microgram group was the one that had the best lifestyle benefits. Okay, slightly more side effects. It was most clinically meaningful. The baseline testosterone was supposed to be completely useless. Don't test it in women. You can't use that to test if they have androgen deficiency.
What was the age range in this study?
The age range of this study, I want to say, was also 19 to 68. I don't recall putting it down. I did not. But that was the thing. Most of the women, however, average age was like 55. So this is older women that were being to the study. Bottom line, do we need to treat women with sexual dysfunction like we do men with Viagra? The answer is no. Okay, multifactorial causes for sexual dysfunction with them. No FDA approved way to be supplementing this properly. Now there's an oral methyl testosterone. Don't give it. And ACOG says you need to focus on mental health and other lifestyle benefits rather than, and estrogen therapy. This should not be given, pretty much. This is like an experimental thing at this stage. That's ACOG's official diagnosis on that. Any questions, guys? No. Thank you very much for being a great audience.
Riveting.